All right, then let's begin today's class. Sharon, give me a thumbs up if my voice is clear. All right. All right, we have to start from physiology. We'll finish the reproductive system today. All right. So spermatogenesis and oogenesis that we'll be discussing now. Okay. So spermatogenesis, you should know the basic we have been doing since high school. Okay. So this is what the basic is. They won't actually ask anything related to basics over here. What they are going to ask you is they will ask you the number of spermatocytes, haploid or diploid, how many chromosomes and how many numbers that will be there. They will ask you this. Okay. So in one of the UL questions, it was this, and in NBME also one question was asked regarding this. So you should be knowing this. That's all. It's okay. Just give it a read. No need to go into detail over here. Okay. And yeah, one important point. Yesterday I forgot to mention down when we were doing the Sertoli cells. So write it down. Sertoli cells nourish developing spermatozoa. And how is this process regulated? So it is activated. It is stimulated by FSH. Okay, this line was given in UL, so it is important. So write this down. And next, coming to our spermatogenesis, here small part you have to be aware about tail motility impaired in ciliary dyskinesia cartagena syndrome, whereas tail motility is normal in cystic fibrosis. Okay, so this is the difference in cartagena and cystic fibrosis we have discussed earlier in the respiratory system as well as in the biochemistry. So make yourself clear how the reproductive systems are affected in both diseases. Okay. So that's all about the spermatogenesis. Don't have to study in detail. Just remember the chromosome number and haploid diploid state, and just remember this. Nothing else they will be asking you over here. Okay. Now another one. Coming to the female reproductive hormones, we have estrogen and progesterone. So let's just discuss estrogen. So two important points are there. I'll be writing it down, but before that, let's just see what is given over here. So ovary 17 beta estradiol, placenta estradiol, adipose tissue estrogen aromatization. So this is all the types of estrogen hormones that are secreted over here. Potency, you have to remember that estradiol is more potent. Okay, just remember this order. Coming to development of internal external genitalia, breast, female fat distribution, growth of follicle, endometrial proliferation, and increase in myometrial excitability. This line is very important. Okay, myometrial excitability, endometrial proliferation. This line is very important. Moving ahead, upregulation of estrogen, LH, and progesterone receptor. Feedback inhibition of FSH and LH, then LH surge, stimulation of prolactin, decreasing prolactin is not necessary. Okay, but this line is very important. And yeah, increase in transport proteins SHBG, HDL, and LDL. They have asked somehow in in UL there is one question. They are talking about estrogen and then they ask in the arrows about the HDL and LDL level. I don't know how, but there was no link to it. And you know, in exam also they will be asking you the parameters irrespective of any particular reason. Okay, you should be knowing कि अगर यहाँ पे ये increase होगा तो यहाँ पे it will be decreasing. You should not question कि यहाँ पे तो इसका कोई reason ही नहीं है. Okay, that won't be possible at all and you don't have to think. Anywhere you find कि इसकी वजह से ये increase हो रहा है, mark this irrespective of any situation. Okay, so that's it. Pregnancy 50-fold increase in estradiol and estrogen, 1000-fold increase in estradiol. Estrogen receptors expressed in cytoplasm translocate to nucleus when bound by estrogen. This is very important. This is the pathophysiological basis or the cellular basis that you can say. Okay, तो एस्ट्रोजन रिसेप्टर्स होते कहाँ हैं साइटोप्लाज्म में, बट देन दे आर ट्रांसलोकेटेड टू न्यूक्लियस. दिस line is very important. Now two important lines that I want you to write down is estrogen ka functions, most commonly how the questions are asked and on what the questions are asked. So proliferation and development of ovarian granulosa cells. Okay, this is the first function that you have to be aware about. And another one is lower uterine threshold to contractile stimuli during pregnancy. So these two lines are from NBME. These two lines are from NBME, and so many questions have been asked on the estrogen and progesterone function. And these 2 points were most commonly asked everywhere. Okay, so I think you should know this, very important. And yeah, one more thing, be thorough with this diagram. Ki theca cells mein what functions are happening and granulosa cells mein what is happening. You can see the granulosa cells mein aromatase say there is aromatization. Like testosterone से estrogen बन रहा है, that is what known as aromatization. तो इट इज अकर इन ग्रैनुलोसा सेल्स. वेयर थीका सेल्स में क्या होता है, कोलेस्ट्रॉल से ये एंडोस्टैंड बन रहा है. ओके, देन दिस एंडोस्टैंड एंडो sorry androstenedione is then transported to the thick granulosa cells, and then it is converted to estrogen from testosterone. Okay, so ये very important, एनबीएमई में काफी सवाल आए हैं. Okay, see reproductive mostly 70% they will be focusing on physio and embryo only. बाकी 30% they will focus on pathology. Okay, यहाँ पे physio और embryo बहुत important है. So it is similar to endocrine system. We have to be thorough with all the hormones present in the female. Okay, so progesterone, corpus luteum, placenta, adrenal cortex. These are the sources of progesterone. Let's just see what they have over here. During luteal phase, prepares uterus for implantation of fertilized egg. Okay, stimulation of endometrial glandular secretion and spiral artery development. This is important. Production of thick cervical mucus inhibits sperm entry into uterus. Important. Prevention of endometrial hyperplasia. Important. Body temperature. Important. Estrogen receptor expression decrease. Important. Decrease in gonadotrophic secretion. So everything is important. Each and every line has one question. Okay. During pregnancy, this was during the luteal phase. Okay. There are three phases in a menstrual cycle. The luteal phase is one of them. During pregnancy, what happens? Maintenance of endometrial lining in pregnancy, decrease in myometrial excitability, decrease in contraction frequency and intensity, decrease in prolactin action on breast. So see, these are completely opposite to those of estrogen. ओके, whereas estrogen में prolactin secretion बढ़ाएगा, progesterone decrease करेगा. Estrogen will increase the myometrial excitability, progesterone will decrease it. Okay, so you should be aware about the functions, difference, and everything. So fall in estrogen and progesterone after delivery, this inhibits prolactin, and as a result, lactation occurs. Okay, simple है. So like progesterone is an indication of ovulation. If in the question they ask what, they will give you blah blah. They will give you the case ki 20-year-old came and pregnant and feeling of symptoms of signs of pregnancy, and now you will say, they will be asked what is the best marker for pregnancy, or you can even say ovulation. Or another type of question is, they will say how to know whether the girl is at her peak in ovulation. Both the answers progesterone. Okay, both the answers are progesterone. This is very important question. They will try to confuse you so many times regarding progesterone, estrogen, FSH, LSH. Okay, so these are the few one liners, and ये सारे one liners आपको आने ही चाहिए. These are the so many questions have been asked regarding the differences between estrogen and progesterone. So you should be knowing that properly. Okay. All right, moving ahead. Oogenesis, similar to spermatogenesis, you don't have to focus on the detail. Just focus on diploid phase कौन सा है, haploid phase कौन सा है. Here another line that you have to remember here is Meiosis 1 is arrested in prophase 1 for years until ovulation. Meiosis 2 is arrested in metaphase 2 until fertilization. These two lines are very important. You will may, I think, 2 to 3 questions are there. Okay, so this becomes important. Exam में NBME में I haven't seen any question related to this, but UL में it's pretty important. 2 3 सवाल है मतलब करने ही पड़ेंगे. Okay, moving on to ovulation. So follicular rupture and secondary oocyte release caused by sudden LH release, that is LH surge at mid-cycle. Estrogen normally inhibits LH release, but high estrogen at mid-cycle transiently stimulates LH release. So LH surge, ovulation. Now see, here they have talked about the important function, and this is what you have been taught in the OBGYN also, like in more detail. Okay, estrogen normally inhibits LH. Okay, but if increase in estrogen is there, then it will stimulate LH release. This is an important concept. You have to keep this in mind. Okay, आपको एस्ट्रोजन का देखना पड़ेगा कि in the exam what they will do is, in the exam they will either give you a particular case, so you have to pick out कि whether the estrogen will be increased in this case or not, or it will be normal. Okay, अगर normal होगा तो LH inhibit होगा, and if the estrogen has increased to so much level, then LH will also increase. So this is how the case will be coming to you, and you have to be aware about it. All right. Metal smudge, pain with ovulation, associated with peritoneal irritation from normal bleeding upon follicular rupture, typically unilateral and mild, but can mimic acute appendicitis. They haven't asked any particular question regarding this. No particular question, but in UL at so many places they popped up in options. Okay, so options में आया है, so it is our duty to do that properly. Okay. Coming to menstrual cycle, this diagram they have given perfectly. Just remember these curves and remember this curve, because in NBME they have literally given the curve. Okay, NBME mein they gave the curves as an option A, B, C, D, and they made the wrong curves. So you have to identify which is the correct curve. Okay, so curves you have to remember. All right, because in one of the NBME they have given this term. Okay, another thing. Follicular phase can fluctuate in length. Follicular growth is fastest during the second week of follicular phase. Luteal phase is fixed 14 days after which menstruation occurs. Estrogen stimulates endometrial proliferation. Progesterone maintains endometrium to support implantation. Decrease in progesterone, decrease in fertility. Okay, so इसमें से last 3 points high yield. Okay, if even in the question regarding progesterone they can ask you if you want to assess the fertility of a girl, or fertility of a girl child, you will be checking for progesterone level. Okay, so this is all the basics of OBGYN that you have already studied. This is just a revision for you if you have studied that well. Okay, अगर नहीं पढ़ा है, no problem, you have to put in more efforts over here. Okay, so yeah, just remember along with this curve, also remember the level of hormone कि 14 डे के बाद ovulation के बाद होता क्या है. Ovulation के बाद there is increase in progesterone, and LH is surge at the ovulation cycle. So this all you have to remember. Before ovulation estrogen was high, after ovulation progesterone is high. So all these small things you have to observe and you have to keep this in mind. All right, coming to abnormal uterine bleeding. So abnormal uterine bleeding. Okay, okay, one important point, both estrogen and progesterone levels decrease if no fertilization occurs. Okay, so ये line याद रख लेना. In one of the questions in UL they gave this, so you have to remember this. All right. Moving ahead to abnormal uterine bleeding. In abnormal uterine bleeding, deviation from normal is not necessary. Just remember the causes: structural and non-structural. Structural may there will be some like outgrowth involved. In non-structural, it is because of the blood problem. Okay, simple. Now, see this here they have given it so beautifully that in the old edition we have to write by ourselves. Okay, so this new edition is very good in this case. So let's just see pregnancy, and mark my word, this is very high yield. Okay, So many questions have been asked on pregnancy in exam also. I was asked in NBME also, and in UL also. So many questions are there. So mark the pregnancy as very high yield because they will be asking you the parameters over here. What are the changes in parameters? Mostly regarding this. Okay. So let's just see what is given here. Fertilization most commonly occurs in the upper end of fallopian tube, the ampulla. First important point. Occurs within 1 day of ovulation. Second important point. Implantation in uterine well occurs 6 days after fertilization. Third important point. Syncytial trophoblast secrete HCG, which is detectable in blood 1 week after fertilization and on home urine test 2 weeks after fertilization. This line is very important because they have asked questions in the NBME. How is the HCG test? When is the HCG test reliable? Okay, or when the levels of HCG can help you detect the pregnancy, or after how many weeks the pregnancy will be detected in the home urine test. Okay, so this is very important. बहुत commonly पूछा है. So another thing is, yeah, so gravidity, validity, this you have to, they won't ask about gravidity, validity, they will give you in the question. A female G3P4, something like this. Okay. So even if you don't know, it's okay. इतना use नहीं है यहाँ पे. Step 2 सीखे में it is used. Okay. Step 1 में no matter, ये सब छोड़ दो. इतना डिटेल में जाने की जरूरत नहीं है. But overall, pregnancy is very important. Yeah, this graph is also important. The placental hormone secretion generally increases over the course of pregnancy, but HCG peaks at 8 to 10 weeks of pregnancy. So ये देखो, this is about HCG and human placental lactogen is the highest. Okay, so confused mat hona. If they ask you irrespective of the weeks, then you can go for HPL. If they specifically mention you before 10 weeks, you should go for HCG. Okay. Now physiologic changes. Here how so many questions have been asked. So each and every system is important. Okay. Physiological parameters आपको आने चाहिए. So maternal changes that nurture the developing fetus and prepare the mother for labor and delivery. Okay. Mediated by hormones and mechanical effects of gravity. तो चलो cardiovascular का देखते हैं. Decrease in afterload, increase in blood volume. Okay. So stroke volume, cardiac output, placental perfusion increases. HR is the major contributor to CO in late pregnancy. Hemodilution, decrease in oncotic pressure, peripheral edema. So what all is important over here is SVR, reload, and yes, SVCO. Okay, directly questions आएंगे. So like याद करना ही है. Directly पूछेंगे they will. What is the change in the afterload, preload, stroke volume, heart rate, cardiac output in the pregnancy? So you should remember the arrows. Coming to second, endocrine. Insulin resistance and secretion, increase in lipolysis and fat utilization, so pituitary enlargement, so increase in ये TBG, CBG and SHBG. Endocrine का इतना important नहीं है, just remember insulin resistance. Insulin resistance is very important. Okay, moving ahead. Gastrointestinal, decrease in motility, decrease in LEH tone, gallbladder stasis, constipation, gallstones, सब कुछ हो सकता है. Okay, not important. Hematology. Dilutional anemia, very important. What is happening in dilutional anemia? Plasma volume and RBC mass is increasing. Hypercoagulable state due to blood loss at delivery. That's it. So इसमें dilutional anemia and ये बहुत important है. Hypercoagulable state due to blood loss of delivery, very important. Okay, the things that I am highlighting, direct questions have been come, and जो highlight नहीं कर रहा हूँ, you can leave that. Just give it a read. Musculoskeletal, joint laxity and lordosis, no, not important. Skin, hyperpigmentation, melasma, all this stuff can occur. Stag, gravidum, stretch marks can occur. Vascular changes, spider angioma, palmar edema can occur. So yes, skin is important. All right. Renal, vasodilation, so increase in renal plasma flow, increase in GFR, decrease in BUN, decrease in creatinine. This is very important. Renal ka also they ask. Okay. And there will be mild glucosuria, so you don't have to worry about it, and even proteinuria. Okay, because pregnancy है, बेबी से proteins निकलेंगे, leak out होंगे, so there is supposed to be glucose and protein loss in the urine. Okay, coming to respiratory center stimulation, chronic hyperventilation, increase in VT and change RR. This was asked in UL. Okay, ये old books में नहीं है. This is given in the new books. based on the information given in UL. So this becomes very important. Okay. So as a result, there will be respiratory alkalosis. In the NBME, they ask कि pregnancy में कौन सा metabolic disorder होता है. Okay, this is not given anywhere. But in NBME, they have asked pregnancy में which metabolic disorder occurs. So you will say respiratory alkalosis. Okay, so all these are important. Let me see कोई और point छूट तो नहीं गया. Okay, two important points they have not given here. Let's just write it down. Red cell mass increase, EPO increase, hematocrit decreases, so there is dilutional anemia. Okay, so these are also parameters that they ask with dilutional anemia. फिर yeah, plasma volume. Along with that, they ask renin. Renin increases, so there is increase in salt water retention. Okay, they have asked this also. और कुछ याद करना है. Yeah, so here in the respiratory there will be increase in tidal volume also. Okay, and another thing, here they have mentioned hypercoagulability, right? This hypercoagulable state. So another thing that you have to remember here is there will be increase in fibrinogen. Okay, so all these parameters are very important. The ones that I have highlighted, the ones that I have written extra, very important. All of this is one question. एक क्वेश्चन सब में से आया है. Okay, and pregnancy में you should be knowing where it occurs, at what day it occurs, fertilization, and what day you can like when you can detect at home that the lady is pregnant, and the hormone that have been increased, HPL and HCG. Okay, so pregnancy and market very high yield. Be sure to know each and everything over here. Coming to HCG, another high yield. Why? Let's just see. Since it is synthesized by sensitive trophoblast of placenta, maintains corpus luteum for the first 8 to 10 weeks of gestation by acting like LH. Luteal placental shift is complete after 8 to 10 weeks. The placenta synthesizes its own external progesterone and corpus luteum degenerate. Okay. So now here the question arises. In okay, which structure will maintain progesterone levels after fertilization? Okay, so after fertilization means 8 to 10 weeks may corpus luteum is responsible for handling the progesterone levels. But if they ask after 10 weeks, your answer will be placenta. Okay, so this small thing you have to keep in mind. Moving ahead, we have used to detect pregnancy because it appears only in urine. Okay, has identical alpha subunit as LH, FSH, and THH. States of increased HCG can cause hyperthyroidism. Now, remember one thing: if they are talking about thyroid hormone, okay, and in the question they will ask what other hormones can increase or decrease with thyroid hormone changes, and options will be so many hormones, and even HCG will be given. Your always the answer should be HCG. So many questions are there in UL also, so you will get the idea what I am talking about. अगर THH या thyroid के साथ if they are asking what other hormone levels will fluctuate because of the similar structure, so you will mark HCG. Okay. HCG is increase in multipetal gestation, highlighted from moles, choriocarcinoma, Down syndrome. HCG decreases in ectopic pregnancy, adverse syndrome, Patau syndrome. Okay, so all these are very important. And yeah, as I told you, after 8 to 10 weeks, में corpus luteum maintain करता है. So another sentence how they can frame this is it maintains in first trimester. All right, 8 to 10 weeks है. So you can take a first trimester में it will maintain progesterone level. All right. So this is all about HCG. Now coming to HPL. Only one line you have to remember about HPL. It is also called human chorionic somatotrophin. This is not a line. The line is promotes insulin resistance to supply fast growing fetus with glucose and amino acids, gestational diabetes. Now one thing in the question, whenever you have association of diabetes plus pregnancy, and if they ask which hormone is responsible, always go for HPL. And this they have asked so many times. I got this question in the exam also. So अगर diabetes और pregnancy का वो लोग association मांग रहे हैं, you should be knowing that HPL is responsible for this. And why? Because it causes insulin resistance in the pregnancy. All right, very important. Now see, this Apgar score they haven't asked particularly. They haven't asked particularly, but they have given in the question. He, the patient is having score one, score zero, score two. So we have to remember that way. Just remember कि सब में क्या features है. Okay? They won't ask you what is the Apgar score or calculate the Apgar score, but in the question only they will give you. So you should know this. All right. Low birth weight defined at less than 2.5 kg caused by prematurity associated with increased risk in SIDS and with overall mortality. Alright, that's it. But ये hormones आपको अच्छे से आने चाहिए, pregnancy अच्छे से आनी चाहिए. Okay, because most of the questions will be based on physiology only. Alright, moving on to more such hormones, we have lactation. So after parturition and delivery of placenta, rapid decrease in estrogen and progesterone disinhibits prolactin. We saw in the progesterone कि pregnancy के बाद एस्ट्रोजन और प्रोजेस्टेरोन डिक्रीज हो जाता है क्योंकि प्रोलैक्टिन इंक्रीज हो जाता है. Okay, and this prolactin is what responsible for production of milk. Okay, so initiation of lactation. Suckling is required to maintain milk production and ejection since increase in nerve stimulation, increase in oxytocin and prolactin. Now one more point. Initiation of lactation is by prolactin. Okay, initiation is by prolactin, but to maintain, that is production and ejection, it is by oxytocin. Okay, so these two differences you have to remember. So prolactin induces and maintains lactation and decreases reproductive function. Oxytocin assists in milk letdown, also promotes uterine contraction. All right, so this is you have to remember. Now, breast milk. Some features about breast milk. Ideal nutrition for infants less than 6 months old. Contains immunoglobulin, conferring passive immunity IgA. Breast milk reduces infant infections and associated with decrease in risk for child to develop asthma, allergies, diabetes mellitus. Guidelines recommended exclusively breastfed infants get vitamin D and possibly iron supplementation. Okay, so now there are two questions over here. In the ethics, okay, ethics may they will give you a case ki a female came with a 2 to 3 months old baby and she was against breastfeeding. So now they ask you what you should suggest to the female. Okay, so suggestion will be always like this: ki less than 6 months baby should be breastfed, must be breastfed, and along with this you will along with this you will explain to her about the benefits. Okay, this is the question asked in ethics. And another question that they ask is, uh, yeah, female will say the baby was exclusively fed on breast milk. Okay, exclusively fed on breast milk. So in the question, they will ask what is the deficiency over here. So deficiency will be vitamin D and iron deficiency. Okay, vitamin D and iron deficiency is important. Okay, vitamin D and iron important. You should know this. Breastfeeding facilitates bonding with child. Breastfeeding or donating milk decrease the risk of breast and ovarian cancer. Okay, so this is all about lactation. Moving to the menopause. Menopause, diagnosed by amenorrhea for 12 months, decrease in estrogen production due to age-linked decline in number of ovarian follicles. Average age at the onset is 51 years. So in the question, they will give you from 49 to 52. Okay, 49 years, sometimes even 47, 48 तक भी जा सकता है. Okay, usually preceded by 4 to 5 years of abnormal menstrual cycle. Source of estrogen after menopause becomes peripheral conversion of androgens. So increase in androgen, there will be hirsutism. All right. Increase in FSH is specific for menopause because lots of negative feedback on FSH due to estrogen. Okay, I told you कि estrogen का FSH और LSH दोनों पे negative effect होता है. Okay, but after menopause estrogen is less, so FH and LH, FSH and LH both will increase. Okay, so let's just see what are the questions that they ask. Hormonal changes, increase in estrogen, increase in FSH, increase in LH, increase in GnRH. Okay, so hot flashes, atrophy of vagina, osteoporosis, sleep disturbances. Menopause before age 40 suggests primary ovarian insufficiency. Premature ovarian follicle may occur in females who have received chemotherapy and radiation therapy. So what is important over here is you have to remember these features. Okay, along with this hormonal changes. Now in the question you have to remember, yeah, they are talking about 49 to 50 years of age. It means the menopause has occurred. Menopause has occurred. Okay, you have to keep this in mind. Another thing, yes, that's only hormone change and that's it. Okay, so menopause K, they literally ask the lab values, and lab values are the hormone change. All right, moving ahead, androgens. So testosterone, DHT, androstenedione. So source DHT and testosterone from testes, androstenedione from adrenal. Now let's just see what happens here. Testosterone का देखते हैं. So differentiation of epididymis vast difference in seminal vesicles except prostate. Internal genitalia except prostate. Growth spurt, penis, seminal vesicles, everything, deepening of void, closing of epiphyseal plates, and libido. So all these are functions of testosterone. Coming to DHT, early and late, differentiation of penis, scrotum, prostate, prostate growth, balding, sebaceous gland activity. See, basically they won't be asking you about the individual functions of DHT, but whenever the prostate will be involved, na, the first hormone that you should link is DHT. Okay, either you are studying pharma or you are studying physio, patho, anything. If prostate is the problem, instead of testosterone, think about DHT. In testosterone, they ask you the function. In DHT, they won't ask you the function. Okay. Coming to testosterone is converted to DHT by 5-alpha reductase, which is inhibited by finasteride. Drugs are important. We'll be doing that later, but here also just keep in mind. In the male, androgens are converted to estrogens by aromatase in the adipose tissue and testes. Okay. Now, anabolic androgenic steroid use, most commonly asked question. Okay. So, increase in fat-free mass, muscle strength, performance, suspect in males who present with changes in behavior, aggression, gynecomastia, acne, and small testes. So that is hypothalamic pituitary gonadal axis inhibition, decrease in intratesticular testosterone, decrease in testicular size, sperm count decreases. Females may present with virilization. Now see how the question will be coming over here. Gym guy or athlete, fat free body, muscular body, small testes. Okay, this will be given. Another question, this will be same and plus aggression. Okay, this is second question, this is first question. Coming to third question, same plus gynecomastia. And in the option, they will give you anabolic steroid use. Okay, so confused nahi hona hai. Look at this parameters. Another thing, they will ask you in arrow questions about this. Intratesticular testosterone, testicular size, sperm count, everything they will ask. Okay, so this is very high yield, and they will definitely ask one question related to this. Okay, so see, this page is very important. We have talked about hormones and stuff, so that's all about reproductive system is hormones and everything. All right, now see, 10 stages of sexual development. They actually NBME hasn't asked, but Yuval has asked 2 3 questions. Okay, and they haven't shown the image. They have focused on the language. So what they will do, they will give you the explanation and you have to pick out the years. Okay, NBME hasn't asked, so just do it. Easy hai, nothing to worry about. Coming to precocious puberty, appearance of secondary sexual characteristics, that is puberty tellus before the 8 years of age in female and 9 years in male. This age is very important because based on this age, you will make the diagnosis. Increase in sex hormone exposure or production, increase in linear growth, somatic and skeletal maturation, premature closure of epiphyseal fluid, so it will be short stature. Okay, types में central and peripheral. Central में increase in GnRH secretion, peripheral में increase in sex hormone production or exposure, that is exogenous, or there will be some cancer. Okay, so central and peripheral they don't ask the causes, but this 8 years and 9 years wala they will ask. And if they want to ask you about the central, directly think about the pituitary problem. If they ask about the periphery, think of some exogenous use or some cancer is produced in the body. All right, coming to delayed puberty, absence of secondary sexual characteristic by the age 13 years in females and 14 years in male, hypergonadotrophic hypogonadism, hypogonadism. Now see, when we do in the pathology, this hypergonadotrophic hypogonadism and all those stuff, they never ask. They never asked, so we won't waste time on that. Yuval has asked 2 3 questions only. NBME never. Okay, so let's not waste time over there. Let's just move to pathology now. Physiology is done. So I'm repeating again. Physiology may it's all about hormones over here, similar to endocrine. Okay, do the hormones properly, your pathology will also be good. Okay, and yesterday we did anat and embryo. That is also very important. So this system is typically about memorizing the endocrine, memorizing the hormone and selecting the answer. Okay, so let's start with the pathology now. All right, these two are very important. Okay, so let's just see what we have to remember here. First of all, you have to remember the chromosome. Okay, before that, this line, aneuploidy most commonly due to meiotic non-disjunction. Meiotic non-disjunction very important. Directly they have asked the question, they will give you a description of this or either this, and they will ask what is responsible for this condition. So due to meiotic non-disjunction, this is very important. So let's just see the features over here. Small form testes, infertility, tall stature with uninucleate proportions, gynecomastia, female hair distribution, may present with developmental delay, inactivated X chromosome, and increased risk of breast cancer. So these are all the features. Okay, most commonly they will be giving you gynecomastia only. Okay, gynecomastia and this hair distribution like female. Okay, so this is very important. And let's just see the lab values that they will be asking you. This genesis of seminiferous tubule. So decrease in inhibin B is going to increase in FSH. We saw this in the embryology only yesterday. Sorry, anatomy. Certainly cells वाले section में seminiferous tubules में. If inhibin B will increase, so FSH will decrease. Okay, so this is what you have to remember. Abnormal Leydig cell function, so decrease in testosterone, increase in LH. Okay, so in the question, either they will ask you to diagnose or they will ask you to go with the arrow question. Okay, and in one question only, they will give you all these parameters: inhibin B, FSH, LH, and testosterone. Everything will be asked in one question only. You have to select the correct arrow. All right. So that's it for the Klinefelter syndrome. Coming to Turner syndrome. Now, one thing we did this in the CVS. Turner syndrome का important link is coarctation of aorta. Okay. Turner syndrome के साथ coarctation of aorta is very important. Now see here. Short stature, SHOX gene, preventable with growth hormone therapy. It is okay. Ovarian dysgenesis. There will be streak ovary. There will be broad chest with widely spaced nipples. Bicuspid aortic valve, coarctation of aorta, femoral digitated less than the brachial pulse. Okay, so this all very high yield. The same lines will be used in the case. Now, apart from this, sometimes they have asked about cystic hygroma. I told you yesterday that the branchial cyst is on the lateral side, hypoglossal duct is on the midline, and if it is on the posterior, there is some cyst. It is cystic hygroma. Okay, and the most important association of cystic hygroma is Turner syndrome. All right, horseshoe kidney, high arch palate, short foot metacarpal, not more common. Okay, one important line: no bar body. Okay, no bar body over here. So menopause before menarche, decrease in estrogen leads to increase in LH FSH. Okay, another thing. Meiosis errors usually occur in paternal gametes, sperm missing the sex chromosome. Mitosis errors occur after zygote formation, the loss of sex chromosome in some but not all cells. Okay. Another thing, mosaicism is associated with increased risk of gonadoblastoma. Pregnancy is possible in some cases by IVF, mostly IVF. So now what all you need to remember here is, see this, you know what to remember. Over here, remember the lab values. Another, the meiosis and mitosis all align. And next one is, they ask how to how to develop pregnancy in this patient. They will give you the case of Turner syndrome, and then you have to remember, you have the first thing you have to remember is sorry. So yeah, and then they will ask how to develop the pregnancy in this patient. So your answer will be IVF. This question is asked in NBME as well as in UWorld. Okay, simple question. So just don't worry about it. And yeah, how UWorld is both UWorld and NBME. The most common way how they have presented Turner syndrome is they will give a small child, and plus you have to see the widening of neck. Okay, there will be widening of neck from year to year. So it means कि आपको shoulder and neck में difference दिखेगा ही नहीं. Small child mostly girl का है, and that image is common everywhere. Okay, so वो क्या होगा, neck will be directly joining into the shoulder. Why? Because there is coarctation of aorta. Okay, so coarctation of aorta की वजह से it is bulging out, and पूरा neck ही इधर से attach हो रहा है. Okay, so remember this. This is the most commonly asked question in US. All right, let's just move ahead. Double Y males, ignore this. अभी याद करने का जरूरत नहीं है. It is all a part of step 2 CK. All right, let's come to the next part. Other disorders of sex development, ignore this. Yeah, you can remember this table if you want to, but this is only asked in UL. In all the NBME, even in the old NBME, new NBME, they have never asked. Even this, भूल जाओ. Okay, this is the very detailed information. This you have to do it from step to CK. For step to CK, step 1 में they don't ask anything related to this, so we should not waste time here. ये table भी नहीं पूछते, but if you want you can just write it down, because in UL ना they have asked the levels of LH and testosterone. Arrow का पूछा हुआ है. Okay, so अगर आपको करना है, if you want to do it, or else not required. Okay, moving ahead. Now these all are very important. Okay, so we'll do them one by one. Aromatase deficiency. You should know the function of aromatase. What happens in aromatase? Testosterone converts to estrogen. Okay, so let's just see. Inability to synthesize endogenous estrogen. Autosomal recessive. During fetal life, DHEA is produced by fetal adrenal gland, cannot be converted to estrogen by placenta, and is converted to testosterone peripherally. Virilization of both female infant and mother. So here the case will be virilization of female. Okay, now viralization means, what does viralization mean? What does viralization mean? Viralization means there will be hirsutism.
Mhm.
The yeah, Sharon, say, bolo bolo.
It's like opposite of the like internal organs will be of one sex, but the external organs, genitalia, will be of another.
Yeah, and sometimes there will be ambiguous genitalia also. Okay, I you know the word
Okay.
ambiguous, right?
Yeah.
Yeah, so mixed genitals भी हो सकता है. Okay, so if in the question virilization of females is occurring with all these factors, think about aromatase deficiency. Okay, now see, virilization of females occur in so many things. In endocrine also we have studied three hormones, but उसमें क्या था, छोटे बच्चों में होता था. But here it is going to be in mother as well as the girl child. Or okay, let's just see other symptoms. Androgen insensitivity syndrome, इसमें क्या होगा? डिफेक्ट इन एंड्रोजन रिसेप्टर्स रिजल्टिंग इन फीमेल अपियरिंग जेनेटिक मेल. तो यहाँ पे मेल में प्रॉब्लम होगा. सो जो एरोमेटिक डेफिशिएंसी में हो रही थी फीमेल्स में, सेम थिंग विल बी अकरिंग इन मेल. लेट्स जस्ट सी अदर इंपॉर्टेंट. Female external genitalia with scant axillary hair, pubic hair, rudimentary vagina, uterus and fallopian tube absent due to persistence of anti-mullerian hormone from testes. Patients develop normal functioning testes, often found in labia majora, surgically removed to prevent malignancy. Now see, androgen sometimes they what they do is they will give you the diagnosis of androgen insensitivity syndrome, and then they will ask you why you need to remove testes from the labia majora to prevent malignancy. This question is there in NBME. Okay, this is one question. So if they're asking you about AIS, that is androgen insensitivity syndrome, consider a male with ambiguous genitalia और external female की तरह है और internal भी थोड़े बहुत male और female दोनों है. Okay, so basically he is a male in female's body. All right. तो ये लैब वैल्यूज है इंक्रीजिंग टेस्टोस्टेरोन एस्ट्रोजन एलएच. so this is you have to remember. Coming to 5 alpha reductase deficiency. 5 alpha reductase में क्या होता था? टेस्टोस्टेरोन is not getting converted to DHT. So अभी क्या होगा? Autosomal recessive, sex limited to genetic males because it is about males only. Inability to convert testosterone to DHT. So atypical genitalia. Yeah. Atypical genitalia until puberty, when increasing testosterone causes masculinization or increasing growth of external genitalia. Testosterone and estrogen levels are normal, LH is normal or increase, internal genitalia are normal. Okay, so DHT का function गया तो DHT was responsible for forming external genitalia. So mostly the problem will be in external genitalia. बाकी अंदर का normal होगा. Okay, coming to Kalman syndrome. Kalman syndrome very underrated, but they have asked in NBME. Okay, let's just see. Failure to complete puberty, a form of hypogonadotropic hypogonadism, defective migration of neurons, and subsequent failure of olfactory bulbs to develop. Now, see one thing. If they are giving you any LH, GnRH, or FSH ka problem, plus they are giving you some olfactory problem. Olfactory problem means taste ka problem. So you can say dysgeusia. This is the term used for decrease in taste. तो dysgeusia plus hormones का problem है. Think about Kalman syndrome. But yeah, remember this should be present. Otherwise, you won't see it as a Kalman syndrome. Okay? Kalman syndrome अगर diagnose करना है, so taste के related भी कुछ symptom they should have given. Okay? So infertility, low sperm count in males, amenorrhea in females. That's it. Okay? So these four are very important and they are going to confuse a lot over here. So इसमें एक simple सा फंडा कर लो, hormones का function याद कर लो, and you are good to go. Alright, moving ahead, placental disorders. Placental disorders very important, but not in too detail. Okay, the detail we'll be doing in obsgyne in step 2 CK. For step 1, just remember the definition and one or 2 points. Okay, तो चलो देखते हैं. Placenta accreta spectrum. Okay, तो प्लासेंटा एक्रेटा स्पेक्ट्रम का पहले कर लेते हैं. Formerly called morbidly adherent placenta, abnormal invasion of tropoplastic tissue into uterine wall. Risk factors, yeah, here they will be mostly focusing on risk factors. So C section सब में important है. Okay, C section is very important. Then placenta previa, maternal age, multiplicity. Okay, three types है, accreta, increta, percreta. Accreta में myometrium, increta में invades into myometrium, percreta में completely invades to myometrium and serosa, sometimes extending into adjacent organ, bladder. So, if they want to ask you about this, most commonly they will give you the bladder problem along with placenta problem. Okay, and in the question, in the option, they will say that placenta has attached and invaded the entire myometrium. Okay, this line will be given. So this is what you have to remember here, just definition. Okay, so let's just see. Presence with difficulty separating placenta from uterus after fetal delivery and severe postpartum hemorrhage upon attempted manual removal of placenta. Okay, so this is, ये तो सब में common ही होते हैं. Okay, placenta pathology है, so this is going to be common in everything. So the case, आपको जब भी placenta का आएगा ना, classic case will be they will give bleeding, then they will say C section was done, then they will say bladder problem. So bladder problem is only common in placenta accreta. Previa abruptia में there is no bladder problem. Okay, so ये सब याद रखना है. Moving to placenta previa. Okay, placenta previa. Attachment of placenta over the internal cervical OS. A preview of placenta is visible through the cervix. Okay, now they will say the placenta is visible towards the cervical hole or internal cervical os. Clear, this line will be given in the question. ऐसा दिख रहा है? Placenta previa is the answer. Okay, risk factors इसमें भी C section है. Present with painless vaginal bleeding in third trimester. Painless. Okay, now how to distinguish this from placenta abruption? Placenta abruption will be painful and this will be painless. So this one word is also going to help you in the diagnosis. Painless है तो placenta previa, painful है तो placental abruption. Okay. Low lying placenta located less than 2 centimeters from but not covering the internal cervical os. Okay, so mostly आपको question में यही आएगा, cervical os को cover कर रहा है. Okay. Vasa previa. Fetal vessels run over or less than 2 centimeters from internal cervical os. Risk factors, velamentous insertion of umbilical cord. This they will give you in the question. Velamentous insertion of umbilical cord inserts in choriamnionic membrane rather than placenta. Fetal vessels travel through placenta unprotected by wharton jelly, bilobe or subcentric placenta. Now see one more thing. Simple word में अगर हम इसको देखें, so we will say umbilical cord inserts into fetal membrane. Okay, and this is very important. No protection by wharton jelly. Okay, present with painless, ये भी painless होगा. And upon rupture of membranes accompanied by fetal heart rate abnormality, there will be bradycardia. Okay, may lead to fetus. So bradycardia भी है in fetus, painless है, and one line they will be giving you कि यहाँ पे the placenta won't be on the internal cervical os. It will be 2 centimeter low lying. And even this is confusing because placenta previa may be low lying हो सकता है. But you know what the problem is? Problem will be they will definitely give you this line or they will say the placenta has attached somewhere else. Okay, so this line you have to remember over here. Coming to abruption, also called abruptio placenta, premature separation of placenta from uterus point to fetal delivery. Risk factors, hypertension, preeclampsia, smoking, cocaine, abdominal trauma. Presence with abrupt painful vaginal bleeding in third trimester can lead to maternal hypovolemic shock and DIC. Okay, so देख लो, I will discuss all this again. We are remaining with okay, सारे हो गए. So let's just see one important feature from each of this. Placenta accreta है, so bladder का involvement they will give. Placenta accreta में placenta will insert into myometrium. Risk factors C section. Okay. Coming to placenta previa, question will say placenta is visible on the internal cervical os. 99% they will give this. Okay. It is a painless bleeding. Okay, painless bleeding in third trimester. Comparing it with placental abruption, it is a painful bleeding in third trimester, and it is the case where the premature separation occurs. Premature separation is very important. And next one is कि यहाँ पे it can lead to DIC and hypovolemic shock. Coming to vasa previa, Vasa previa में most common case will be bradycardia in fetus. Okay, placenta will be locating 2 centimeter away from the os. Another thing, there will be velamentous cord. Umbilical cord will be inserted into fetal membrane and not protected by Watson jelly. बस इतने ही फीचर्स याद करने हैं. Based on this information only, you will be able to solve all the questions. Okay. Now ये फीचर्स तो याद करने हैं, but along with that, the question will be very tricky for you. Okay, they will say bleeding है, ये है, risk factors, all of that. In question में, in to pick out the risk factors, that is what your job. Okay. So that's all for the placental anomaly. Let's move on to uterine rupture. So uterine rupture, full thickness disruption of uterine wall, prior C-section, abdominal trauma. Present with painful vaginal bleeding, fetal heart rate abnormalities, bradycardia, easily palpable fetal path, loss of fetal station may be life threatening for both mother and fetus. Now one more thing, यहाँ पे भी bradycardia हो रहा है. And in vasa previa also bradycardia is occurring, but here it is painful. In vasa previa it is painless. Okay, another thing, while in vasa previa you won't be able to palpate fetal part, यहाँ पे you will be able to palpate. Okay, that is small differences is what you need to be aware about. Coming to postpartum hemorrhage, so postpartum hemorrhage, greater than expected blood loss after delivery, leading cause of maternal mortality worldwide. So tone, soft boggy uterus. Soft boggy uterus very important. Trauma, lacerations, incision. Okay. Tissue retain products of conception, thrombin. Treatment, uterine massage, oxytocin. If refractory, surgical ligation of uterine or internal iliac artery. Fertility is preserved in ovarian arteries provide collateral circulation. This entire paragraph is very important. Okay. What is important? Soft boggy uterus is important. More than normal blood loss after delivery. This line will be given. After this treatment, they will give you uterine massage or oxytocin. And what you will do? Surgical ligation of internal artery. This is very important. This is most commonly asked. Okay. They will give you soft boggy uterus and उसके बाद पूछेंगे what you need to do. Alright. Ectopic pregnancy, very high yield. Now, they will confuse ectopic pregnancy with the hieratiform mole and everyone. Okay, so let's just see. Implantation of fertilized ovum in a site other than the uterus. Okay, uterus में implantation नहीं होगी, it will be happening somewhere else. Most often in ampulla of fallopian tube. Ampulla. Risk factors, tubal pathologies, scarring from salpingitis, previous ectopic pregnancy. The most important risk factor they will be talking about is previous history of ectopic pregnancy, PID, pelvic inflammatory disease, that is salpingitis. ओके, तो ये दोनों बहुत इंपॉर्टेंट है आपको. यू शुड बी लुकिंग आउट फॉर दिस इन द क्वेश्चन. क्वेश्चन में देखना पड़ेगा, आर दे टॉकिंग अबाउट सम डिजीज, आर दे टॉकिंग अबाउट अ प्रीवियस हिस्ट्री ऑफ एक्टोपिक प्रेगनेंसी. वेरी इंपॉर्टेंट. ओके, location is important. To present with first trimester bleeding or lower abdominal pain, often clinically mistaken for appendicitis. Suspect in patient with history of amenorrhea, lower than expected rise in ECG. Lower than expected rise. See, HCG normally double होता है. Okay, pregnancy के बाद after some time the HCG doubles, but यहाँ पे it won't double. Okay, so it will be lower than expected rise in ECG, and this line they will be giving it. Okay, so confirm with ultrasound which may show extra ovarian adenal mass. Adnexal mass is also another term where you can think about ectopic pregnancy, and treatment they have asked methotrexate. So what all you need to remember here: PID, ampulla, previous history. Then you have to remember bleeding. Then you have to remember HCG will increase, but not will be like what it is expected. Pregnancy के बाद it usually doubles, but here there will be less than double. Okay, and it will show adnexal mass, confused with appendicitis, and last point treatment is methotrexate. Okay, so all these points are very important. Okay, so do this properly. Another important point that they have not given here, if like they might ask you, see how the endocrine endometrium gland will be appearing. So you will say dilated, coiled endometrial gland. This line has been taken from UWorld, so it's very important. Okay, that's all about ectopic pregnancy. So in this postpartum and ectopic pregnancy very high yield. Okay, ectopic pregnancy तो high yield है ही. Okay, बहुत high yield है, so many questions in UL itself. Okay, so ectopic pregnancy को ध्यान से कर. Moving ahead, we have hydatidiform mole. Now again over here, they will be asking you the differences between all of them. And the most commonly they will be asking about HCG levels, fetal parts, is paternal or maternal, and hydropic villi and circum diffused over this they will ask. And what they will ask is, yeah, this this they won't ask, this they will give you in the question. ये question में देंगे. So based on that you have to pick out complete mole है या partial mole है. Okay, another thing, clusters of grapes and snowstorm on ultrasound, very important. ओके, सो ये डिफरेंसेस यू हैव टू रिमेंबर. लेट्स जस्ट सी कि इंफॉर्मेशन में क्या दिया हुआ है. Cystic swelling of chorionic villi and proliferation of chorionic epithelium, only tophoblast. Present with vaginal bleeding, emesis, uterine enlargement more than expected, pelvic pressure pain. Associated with HCG mediated sequelae, that is hyperthyroidism, hyperemesis gravidarum. Now, what is hyperemesis gravidarum? Just right.
Excessive vomiting.
Yeah, vomiting. Another thing, vomiting के साथ और भी कुछ होगा ना. बोलो बोलो. Okay, nausea, vomiting, plus there should be weight loss. Okay, vomiting तो ऐसे भी कोई भी GIT डिसऑर्डर में भी हो सकता है. ऑलराइट,
Uh,
सो वेट लॉस का होना भी जरूरी है. सो वेट लॉस, vomiting, nausea, they all give this about hyperemesis gravidarum. Okay, so see, यहाँ पे भी if they have seen कि HCG increase हो रहा है, if they are saying HCG is increased, so here also they might confuse you with the thyroid problem. Okay, थायराइड का लैब वैल्यू भी पूछ लेंगे. एंड आई टोल्ड यू HCG में भी have discussed कि one of the sub unit of HCG is associated with thyroid hormone also. So you should be remembering this. HCG को थायराइड के साथ लेके चलना. ओके, सो डिफरेंसेस तो आपको याद करने ही है. एंड दीज आर द फीचर्स. एंड अपार्ट फ्रॉम दिस, चलो मैं आपको यहाँ पे लिखा देता हूँ लैब वैल्यूज ऑफ थायराइड विद HCG. Decrease in TSH, increase in TC-T4. So basically it is hyperthyroidism and it can lead to preeclampsia also. Okay, preeclampsia भी झेल सकता है. Okay, so thyroid का is important over here. And okay, that's it. It will be painless uterine bleeding. Okay, so this is about complete and partial mole. Now choriocarcinoma. Choriocarcinoma में पहली बात, most commonly they will give you this X-ray. You have to see cannonball appear. Okay, let's देखते हैं. Rare malignancy of trophoblastic tissue, cytotrophoblast, syncytial trophoblast, without chorionic villi present. Chorionic villi present नहीं है, but उसमें chorionic villi present है. Most commonly occurs after an abnormal pregnancy, that is hydatidiform mole abortion. Presence with abnormal uterine bleeding, HCG mediated sequela, dyspnea, hemoptysis. Hematogenous spread to lungs, so cannonball metastasis. Treatment is methotrexate. So यहाँ पे all the features that are present here won't be present here. Okay, मतलब complete mole या hydatidiform mole से तो ये होगा, but there won't be features like that. Villi present नहीं होगा, fetal pars present नहीं होगा, nothing like that. Most commonly they will be asking about the cannonball appearance in the lung. So mole present with hemoptysis. Okay, mole present with hemoptysis will give you the diagnosis of choriocarcinoma. इजी डायग्नोस आता है, ये सब इजी इजी आता है. बस आपने अगर इंफॉर्मेशन याद कर ली ना, यू आर गुड टू गो विद दिस चैप्टर. ओके, ये टॉपिक भी. ओके, मूविंग अहेड, हाइपरटेंशन इन प्रेगनेंसी. Hypertension in pregnancy, gestational hypertension, BP greater than 140/90 after 20 weeks of gestation. No pre-existing hypertension, no proteinuria, no end organ damage. Hypertension prior to 20 weeks of gestation suggests chronic hypertension. तो इसमें ट्रीटमेंट में आप यही ड्रग दोगे. वी डिड दिस इन द hypertensive drug, hydralazine, alpha methyl labetalol, nifedipine. Okay, 37 से 39 weeks. Most commonly nifedipine is given. So gestational hypertension, uh, after 20 weeks of gestation. Okay, so coming to preeclampsia, new onset hypertension with either proteinuria or end organ damage after 20 weeks of gestation. Okay, onset of preeclampsia less than 20 weeks of gestation may suggest molar pregnancy. It means 20 weeks से पहले था, so it is a kind of chronic hypertension. Okay, but 20 weeks के बाद है, so it is gestational hypertension or it can be preeclampsia if there is end organ damage. Okay, caused by abnormal placental spiral arteries. Now these lines are very important. Abnormal placental or spiral arteries, endothelial dysfunction, vasoconstriction, ischemia. Risk factors: history of preeclampsia, multifetal, chronic hypertension, chronic kidney disease, autoimmune. So this is all और risk factors करने की जरूरत नहीं है, but this is very important. Abnormal placental spiral arteries, endothelial dysfunction, very important. Okay, complications देखते हैं. Complication: placental abruption, coagulopathy, HELP syndrome. कॉम्प्लिकेशन बेसिकली सब हो जाएंगे. renal failure, kidney, uteroplacental insufficiency, bladder problem, everything will be there. Okay, but health syndrome is something unique that we'll be doing here. Treatment: hypertension, IV magnesium sulfate to prevent seizures, definitely with delivery. Now one important point: prophylaxis में you will give aspirin because अगली बार ये एपिसोड ना हो. For that you will be giving aspirin. Read the question properly. What drug should be given in order to prevent such episodes in future? So your answer will be aspirin. And for the treatment, if they are asking, give antihypertensive, and they will say what else can be given. So magnesium sulfate in order to prevent eclampsia. Okay, pre-eclampsia से eclampsia होता है. So if you want to prevent eclampsia while it is in the pre-eclampsia stage, give IV magnesium sulfate. Okay, coming to eclampsia, pre-eclampsia with seizures. That's it. तो अगर ब्रेन इन्वॉल्वमेंट हो रही है इन प्री एक्लेम्सिया, इट इज नॉट प्री एक्लेम्सिया, इट इज नाउ एक्लेम्सिया. ओके, ट्रीटमेंट मैग्नीशियम सल्फेट, एंटीहाइपरटेंसिव, इमीडिएट डिलीवरी. हेल्प सिंड्रोम: preeclampsia with thrombotic microangiopathy of liver. So hemolysis, elevated liver enzyme, and low platelets. That is what the triad. Okay. May occur in absence of hypertension, proteinuria. Blood may show schistocyte. इधर भी schistocyte याद रखनी है. Can lead to hepatic subcapsular hematoma, and it can lead to DIC. Okay. So if in the question they are giving preeclampsia, along with that liver enzymes are increased, platelet count is low, think about HELP syndrome. Okay, so ये pregnancy hypertension is also very important. They have asked so many questions, so ये याद कर लेना. Another important point: while studying about hypertension, you have to remember this supine hypertensive syndrome, also called autocaval compression syndrome, seen at greater than 20 weeks of gestation. So supine position causes compression of abdominal aorta and IVC. So decrease in placental perfusion can lead to pregnancy loss and decrease in venous return. Relieved by left lateral decubitus position. Very very important. UL NBME दोनों ने पूछा है ये. Okay. So if the case will be given to here, when the mother is lining. Okay, when the mother is lining, there is a pain in the abdomen. How is this pain occurring? Sorry, when the mother is lying, there is a pain in the abdomen. How it is occurring? Because of the compression of IVC and abdominal aorta, it is causing ischemia in the placenta. Okay, so there can be fetal loss also because the oxygen won't be reaching there. Another point, they will ask the question, how to prevent this? So simply ask the mother to lie down in left lateral decubitus position. Okay, very important topic. Do this properly. So with this, we are done with the pregnancy wala, obstetrics wala part. We are done. Now we'll be moving to the gynecologic part. So let's just take a 5 minutes break over here, and then we'll start with the gynecology. Okay. So तब तक देख लो. If you have any doubt, ask me. All right, let's begin with gynecology part. Gynecologic tumor epidemiology. We have endometrial, ovarian, and cervical. So this is about incidence and prognosis. Mein cervical, endometrial, and ovarian. So remember this incidence and prognosis. Okay. Moving ahead, we have vulvar pathology. Now vulvar pathology में you have to remember Bartholin cyst. मतलब see, if we look from the gynecologic point of view, na, they don't ask many questions regarding this. Okay, the most questions they will be asking you about imperforate hymen, and they will be asking you about this PCOD and all those stuff. Okay, ये सब पूछेंगे. And ovarian cyst also they don't ask. They will ask about tumors. Okay, so let's just see. We will do everything, but they don't usually ask this. You will maybe hardly 2 3 questions you will find regarding this vulvar pathology. So let's just discuss. Bartholin cyst and abscess due to blockage of Bartholin gland causing accumulation of gland fluid may lead to abscess, usually in reproductive age female. Okay, so only one question was there in UL, and that was also unexpected. How can you go and diagnose about Bartholin cyst and abscess without proper information? Okay, so blockage of Bartholin gland याद रखो, accumulation of gland and fluid याद रखो, simple. And images you can go for. In the image in UL, they gave the image about this lichen sclerosis. They gave this image. So remember the image. Based on that, you will be asked. Okay. Coming to lichen sclerosis, progressive inflammatory disease characterized by porcelain white plaque that can be hemorrhagic, eroded, or ulcerated. May extend to anus, producing figure eight appearance. Increase in incidence in prepubertal and peri or postmenopausal females. Presence with intense pruritus, dyspareunia, dysuria, dyschezia. So अगर pruritus, dyspareunia, dysuria and dyschezia आता है, so you should be thinking about lichen sclerosis. Okay. One more thing. Okay, I'll do that after. Lichen simplex chronicus, hyperplasia of valvar squamous epithelium, present with leathery thick valvar skin with enhanced skin marking due to chronic rubbing or scratching. Okay, benign, no risk of HCC, increase in risk of HCC. This is how you will differentiate. They will in the question they will say increase in risk of HCC, but here there is no risk of HCC. Sometimes the same presentation will be given to you. Okay, क्योंकि यहाँ पे भी priorities है, so rubbing तो होगी, यहाँ पे भी rubbing है, skin marking है, scratching है, तो scratching यहाँ पे भी तो होगी, pruritus है, the female will be trying to scratch it. Okay, so दोनों में they might give you the same condition, but at the end they will mention कि कैंसर होने के चांसेस कितने ज्यादा है. Okay, so that's it. And yeah, another thing, this will be thin and this will be thick. So अगर आपको बोल रहे thin presentation है in the vulva and thick presentation in the vulva, think about like this. Okay, coming to neoplastic vulvar carcinoma, most common is squamous epithelial lining of vulva present with leukopenia. Biopsy often required to distinguish carcinoma from other causes. HPV is the most common cause, 1618 you have to remember, and non-HPV में long standing lichen sclerosis. Okay, done. Coming to extramemory packet disease. So extramemory packet disease, intraepithelial adenocarcinoma and presence with pruritus, erythemas, testing ulcer. Never asked. कभी नहीं आया है. Not in UL, not in NBM. Even this they have never asked, but HPV का है. So we'll be doing that in micro again. That's why I'm covering this up. बाकी vulvar pathology 0.1% chance है कि आपको आएगा. But yeah, imperforate hymen very high yield. Okay, high yield is very high yield. Let's just see what they will give you over here. Incomplete degeneration of central portion of hymen, accumulation of vaginal mucus at the birth, self-resolving bulge in introitus. If untreated, leads to amenorrhea, cyclic abdominal pain, hematocollapse, accumulation of menstrual blood in vagina, bulging and bluish hymen. Now see, imperfect hymen, they will give you this two lines: bulge in introitus and hematocollapse, accumulation of menstrual blood in vagina. So they will ask you, where is the seen? So answer will be either imperforate hymen or incomplete degeneration of central portion of hymen. These two things they will be asking. Okay. So look out for these two things and then only go for this diet. Okay. So and yeah, another thing, bulging and bluish hymenal membrane. Bulging, hymen will be bulging. So these 2 3 points are important to know the diagnosis of imperforate hymen. All right. Tumors Also not commonly asked, but let's just see. Common cell carcinoma secondary to cervical. Okay. Clear cell adenocarcinoma arises from vaginal adenosis, persistence of glandular columnar epithelium in proximal vagina who had exposure to DES. So DES अगर question में दिया है and if they say there is a cancer in vagina, what will be the cancer? Clear cell adenocarcinoma. Sarcoma botrytis, yeah, they have asked this. Sarcoma botrytis is important. Not particularly they have asked. How they have asked this? They have asked rhabdomyosarcoma in girls. Okay, they have asked you this. So we know rhabdomyosarcoma में sarcoma botrytis होता है. So that's how they have asked. Embryonal rhabdomyosarcoma variant affect females less than 4 years age. Spindle-shaped cells, Desmin positive, present with clear grape-like polyploid mass. This is very important. Grape-like polyploid mass in one of the old NBMEs. In one of the old NBMEs, they were showing this vulva of female. Okay, they were showing the vulva of female, and they were showing this grape like mass coming out from this. Okay, grape like mass, it is clearly visible, grape jaisa aapko dikhega. So yeah, sarcoma botrytis, you can keep this in mind. Just remember rhabdomyosarcoma with it. Okay, and clear cell adenocarcinoma ke sath remember DES exposure. All right, nothing else. Baki vulva pathology, not at all high yield. Okay, NBME has never asked. In one of the questions, they ask about sarcoma botrytis and imperforate hymen is high. Okay, so ज़्यादा time waste मत करना. Just read and remember 1 or 2 points from each of them. Okay, coming to cervical pathology. Cervical pathology, first of all, तो आप ये cells देख लो. Now you know why I am telling you this, because you will be confused with the clue cells of bacterial infection. Okay, clue cells में भी cervical infection होता है. So clue cells is seen. Can you tell me the name of organism, Sherin? Sherin, बोलो. क्लू सेल्स किस में दिखते हैं? कौन सा माइक्रोब करता है क्लू सेल्स?
वजाइनल एपिथेलियम के उसमें दिखता है, वजाइनोसिस में,
बैक्टीरिया का नाम?
गार्डेनेला.
परफेक्ट, परफेक्ट. ओके, सो दैट्स इट. तो क्लू सेल्स का और ये डिफरेंस देख लेना, यू विल बी कंफ्यूज. ओके, so let's just see what they have given here. And yeah, cervical pathologies are important. So देखते हैं. Disordered epithelial growth begins at the basal layer of squamo-columnar junction. Transformation zone. Exchange outward classified as CIN1, CIN2, 3. Severe irreversible dysplasia of carcinoma. Now, one of the question in exam, such a stupid question I got, and that question was, they made the diagnosis. They told me that it was CIN. Okay, and in the bracket they wrote cervical intraplexural neoplasia. And in the options, they asked me what type of neoplasia are you seeing. So one was carcinoma in situ, second was invasive carcinoma, third was some other thing, and fourth was some other thing. But I remember that the carcinoma in situ they have talked about here, so I have to mark carcinoma in situ. Okay, this is such a stupid question, I don't know how to mark it. Okay, so carcinoma in situ याद कर लेना, आपको भी आ सकता है ऐसा question. In exam I got this question, so I don't know how they made this. Okay, so yeah, associated with HPV 16 and 18, यहाँ पे भी produce both E6 gene protein that is inhibiting TP53 and E7 inhibiting PRB. These 2 points very important. Coilocytes, these are what coilocytes is: wrinkle, rachmoid nucleus and perinuclear halo. Okay, the coilocytes are important. And may progress slowly to invasive carcinoma. So पहले in situ होगा, फिर invasive होगा. Okay, and detected with pap smear. Presence at abnormal vaginal bleeding, often post-coital. And risk factors: multiple sexual partners, HPV, smoking, early cartridge, DES exposure. Everything is important. Now see, they will give you a classical case. The bleeding is seen from the female after coitus. Okay, so after sexual activity, bleeding is seen. So the first thing is कि bleeding after sexual activity दिख रही है, so it can be normal also. Second, अगर if they have given that there is some HPV growth was also seen, so HPV तो आपका diagnose हो गया. Okay, so these 2-3 points are important. Apart from this, they will ask you about E6 and E7. Okay, and then as I told you, poilocytes and clue cells का difference देखना आना चाहिए. Another thing, CIN is carcinoma in situ. It is not invasive carcinoma. Okay, this question was asked to me. Another, they will give you risk factors. So now in risk factors, if say that if female is exposed to multiple sexual partners, what you should advise? You should advise to use condoms. Okay, this question was asked in NBME or UL. So cervical cancer का they said HPV transfer हो रहा था. So in order to prevent that, you should be advising the patient to use condom. Okay. Second example in NBME was such a stupid question. It was again, it was in the ethics part, and they said कि ask the patient to stay loyal to one partner. ऐसा कौन बोलता है? Ask the patient to stay loyal to one partner. Okay, like I know it is correct, but how they are asking this in the question? Okay, it was totally unrelated. So ethics में ऐसे सवाल आएंगे. So you have to think about it before using. Okay, so condom वाला part, loyal to one partner वाला part, CIN वाला part. These three are very weird questions that they have been asking in the cervical pathology. So keep this in mind. ऐसे questions भी आ सकते हैं. All right. And diagnosis by pap smear and HPV culture. So invasive carcinoma का देख लेते हैं. Pap smear can detect cervical dysplasia before it progresses. Diagnosed via colposcopy and biopsy. Lateral invasion can block ureters and renal failure. So now अगर invasive carcinoma होगा, some extra structures might also get involved. So based on that, you have to decide whether they are talking about CIN or invasive carcinoma. दोनों का diagnosis अलग हो जाएगा. Okay. That's it for the cervical pathology. Keep all these points in mind. They are very high. Now coming to the ovary. Ovary may primary ovarian insufficiency, also called premature ovarian failure, premature atresia of ovarian follicles in females of reproductive age. Okay, Turner syndrome, Fragile X syndrome, and यहाँ पे lab values is estrogen will decrease but LH FSH increase. Remember, estrogen, LH, FSH. Every time they will be asking you. You have to remember one thing कि estrogen दोनों को inhibit करता है जब भी normal होता है. Okay, so यहाँ पे कम हो रहा है तो obviously it will be opposite. If estrogen is in more quantity, then it will also cause LH. Okay, so keep this concept in mind. Present with the signs of menopause before the age of 40. So they will say menopause before 40. Okay, so you have to think about premature ovarian insufficiency. Most common cause of anovulation, pregnancy and PCOD are the most common cause. Baki kuch, so you can just see. Another thing they like to ask about is competitive athletics. We'll be discussing that. Next one, functional hypothalamic amenorrhea. Now, this is also very high yield. So many times this question has been asked. Also called exercise-induced amenorrhea. Severe calorie restriction, increase in energy expenditure, functional disruption of pulsatile GNRH secretion, so decrease in LHH, FSH, estrogen, सब कुछ. Pathogenesis includes decrease in leptin and increase in cortisol. Now, classic case will be given to you. Adolescent female who eats less due to diet issues and works out more. Okay, so this case will be given to you. You need to think about functional hypothalamic amenorrhea. Okay, क्योंकि there will be the disruption of GnRH secretion. GnRH secretion कम हो जाएगा तो सब कुछ कम हो जाएगा ना. Okay, so keep this in mind. Associated with eating disorders and female athlete triad. Triad is decrease in calorie availability, excessive exercise, decrease in bone mineral density and menstrual dysfunction. Now bone mineral density होगा क्योंकि estrogen कम हो जाएगा. Okay, see everywhere everything is connected, so you need to keep your brain open. Coming to PCOD or PCOS, both are same thing. Okay, let's just see यहाँ पे क्या याद रखना है. First is hyperinsulinemia or insulin resistance. Okay, increase in LHS to FSH ratio, increase in androgen from theca internal cells, decrease in rate of follicular maturation, unruptured follicles plus anovulation. So these are the stages that you will be seeing here. All this very important. Okay, so this is what you will be seeing in ultrasound. Another thing, you will be seeing anovulation, hyperandrogenism. So you will be seeing hirsutism and acne. Okay, hirsutism and acne. Apart from this, you will be seeing one important dermatological condition, that is acanthosis nigricans. Acanthosis nigricans कैसे present होता है? In the neck or in the axilla, there will be dark black pigmentation. Okay, dark black, पूरा neck will be black, पूरा axilla will be black. Okay, so it is even seen in diabetes. As you can see in PCOS, insulin resistance है, तो it is obviously diabetes तो होना ही है. Okay, and sorry, I said wrong. यहाँ पे diabetes नहीं होगा, यहाँ पे hyperinsulinemia है. But this condition is seen in diabetes also. Okay, so what else is important is, yeah, treatment they have asked. First one, there will be weight reduction. Peripheral estrogen formation decrease हो जाएगा. Second, OCP, prevent endometrial hyperplasia due to unopposed estrogen. Clomiphene, ovulation induction, spironolactone, all this. So we will discuss this drugs later also. But यहाँ पे इनका one line याद रखना. PCOD, they ask is high yield. Functional hypothalamic hernia, high yield. And CIN, high yield. So this page becomes very high yield again. Okay, let's just move ahead. Primary dysmenorrhea, not asked, but कर लेते हैं. Small thing. Painful menses caused by uterine contraction due to decrease in blood loss and ischemic pain mediated by prostaglandin. Treatment में NSA. Okay, never ask this. Ovulation avoidances, never ask. छोड़ दो. Ovarian tumors. So ovarian tumors में there are two types: epithelial tumors and ovarian neoplasm. Okay, so let's just see. Most common adnexal mass in females greater than 55 years of age, abdominal distension, bowel obstruction, pleural effusion, everything can occur. Okay, as it is a tumor. Okay, advanced age, number of lifetime ovulations, endometriosis, and BRCA, all these things will be there. Risk decreases with previous pregnancy, history of breastfeeding, OCPs, and tubal ligation. This is important. Epithelial tumors are typically serous or mucinous. Monitor response to therapy by measuring CA125 level. Okay, CA125 level, they are not used for screening, but they are used to see the improvement. Okay, CA125 are not used for screening. Okay, you won't use them for screening. Diagnosis के लिए use नहीं करोगे. You will use them to check, but whether after treatment are they improving or not. Okay, germ cell tumors can differentiate into somatic structures. So we'll do the germ cell tumors here. So पहले एक बार ये देख लेते. These are also not commonly asked. Okay, not commonly asked. Just give a read. Serous cystadenoma, fallopian tube-like epithelium, benign. Mucinous, benign. Brenner tumor, usually benign. Nests of urothelial epithelium with coffee bean nuclei. This is important because you have the coffee bean nuclei there. One question is there in UL regarding Brenner tumor. Serous carcinoma, Samoa body, not important. Mucinous carcinoma, malignant rare, can result in pseudoxima peritonei. Pseudoxima peritonei is important, and so one question was there in UL. ब्रेनर ट्यूमर का एक क्वेश्चन एंड म्यूसिनस कार्सिनोमा का वन क्वेश्चन, दैट्स इट. बाकी इस पेज में ये आपको बस रिस्क फैक्टर्स याद करना है, नथिंग एल्स. ओके, coming to the ovarian tumor, and this is very high. Okay. There is ovarian tumors na. First of all, they are most common in reproductive age women. Okay, and this is about germ cell tumors, occurs in 10 to 30 years of age. AFP will be there and beta HCG will be there. क्या शेरिन AFP किस में मिलेगा बताओ वापस. अल्फा बीटा प्रोटीन,
Neural tube defects.
न्यूरल ट्यूब डिफेक्ट. सेकंड
Down
AFP
syndrome.
का डाउन सिंड्रोम, ऑटो न्यूरल, वो सब न्यूरल पे आ गया. आई एम आस्किंग अनदर. AFP और कहाँ पे मिलता है? AFP is a marker in which cancer.
Hepatocellular carcinoma.
Yes, yes, perfect. Okay, so let's just see. सबसे पहले डिसजर्मिनोमा देखते हैं. Malignant, most common in adolescent, equivalent to male seminoma but rare. Sheets of uniform fried egg cells. Tumor markers are HCG and LDH. Now see, ovarian tumors and similarly the male testicular tumors that we'll be doing. Okay, दोनों में you have to remember one pathologic feature, one histologic feature and lab value. दोनों में, because they will be confusing you based on the lab values first. बाकी हिस्टोलॉजिक फीचर तो आप इजीली कर लोगे, बट लैब वैल्यूज का फीचर वेरी इंपॉर्टेंट. ओके, सो लेट्स जस्ट डू. डिस जर्मिनोमा में एचसीजी एंड एलडीएच इंक्रीज हो रहा है. फ्राइड एग सेल्स, so these are what fried egg cells. Okay, coming to second is mature cystic teratoma, also called dermoid cyst. Remember this name. Most common ovarian tumor, cystic mass elements from all three germ layers. Now see, along with mature cystic teratoma, mature cystic teratoma, this is very important. Teeth, hair, and sebum. What they will say is, what they will say, कि they will show you the image of hair. Okay, hair like image they will show you, and along with that, sometimes they will show the image of teeth. In one of the questions in NBME, they showed teeth, and in UL they are showing hair. Okay, so make sure you are thorough with both of them. If both, if they ask you any of them, your answer will be mature cystic teratoma. Okay, may be painful to secondary enlargement or torsion. Monodermal form with thyroid tissue, stoma ovary. Stoma ovary is important. So they will give you an depiction of thyroid gland, stoma ovary. Okay, that's it. So mature cystic teratoma and this germinoma done. Now coming to immature cystic teratoma. Now one important point in this germinoma, I forgot one point. Write it down. There will be clear cytoplasm and central nuclei, and along with HCG and LDH, ALP will also increase over here. Okay, so make sure you know this. Now coming for immature teratoma, malignant aggressive, contains fetal tissue neuroectoderm, commonly diagnosed between age before 20, typically represented by immature embryonic-like neural tissue, not commonly asked, but mature teratoma most commonly asked, immature not commonly asked. Dysgerminoma commonly asked. Yolk sac tumor commonly asked. Let's just see. Also called endodermal sinus tumor. Remember this name. Malignant tumor. Remember this. Yellow friable mass. Yellow friable mass, remember. Scalar dual bodies resemble glomeruli. So let's just see scalar dual bodies. This is what scalar dual bodies look like. Okay. Tumor marker is AFP, occurs in children and young adult females. This is very important. So three germ cell tumors we have done. This germinoma, mature teratoma, and yolk sac tumor. Do this properly because questions will become and they will confuse you based on the lab work. Okay. Moving on to the sex-caused stromal tumors. First, fibroma, benign, bundle of spindle-shaped fibroblast, Meigs syndrome, triad of ovarian fibroma, ascites, and pleural effusion. This is very important, and they will give you one question, one line, pulling sensation in the groin. If pulling sensation in the groin is there, Meigs syndrome. Second, sarcoma, may produce estrogen, usually presents as abnormal uterine bleeding in postmenopausal female. Okay. Certainly, Leydig cell tumor and granulosa tumor very high yield. So, gray to yellow brown mass resembles testicular histology with tubules core lined by pink Sertoli cells, may produce androgen. So, viralization. Now, in the question, they will say uh, tumor in ovary that causes male feature in female. Okay, or they will give you that produces androgen. Okay, so that is Sertoli lytic cell. Remember कि Sertoli cells तो अपने को मिलते हैं मेल में. So you also remember here like that. Granulosa cell tumor, most common malignant sex-caused stromal tumor, predominantly occurs in females in the 50s, often produce estrogen or progesterone, present with postmenopausal bleeding, endometrial hyperplasia, sexual precocity, breast tenderness, everything. The important point that you have to remember here is Carl Exner body. Granulosa cells arrange haphazardly around eosinophilic fluid, resembling primary follicles. Tumor marker is increase in inhibin B. Sorry, only inhibin. Okay, so see, these are what the cells are. Okay, so remember the histology, remember the type of bodies present in each of the tumor, you are good to go. Okay, एक बार recap कर लेते हैं. Yolk sac tumor में muscular developed body. Mature cystic teratoma में teeth, hair, everything, and struma ovary. Rich germinoma में fried egg cells. Then sertoli tumor में male androgens. Granulosa cell tumor में Karl Exner bodies. And what is there? Fibroma में Make syndrome, pulling sensation in the groin. Okay, so this is about the ovarian tumors. Let's come to the last part of, I think, the gynecology. This is also very important. All the conditions are important here. Okay, we'll discuss them one by one. Adenomyosis, the non-neoplastic uterine condition, extension of endometrial tissue into uterine myometrium. Okay, myometrium में problem होगा when the endometrium shifts to myometrium. Okay, so this line very important. Caused by hyperplasia of basal layer of endometrium, presence with dysmenorrhea, abnormal uterine bleeding, uniformly large soft globular uterus. Okay, so these two lines are very important. What is that? This first one, and second one is abnormal uterine bleeding and uniformly enlarged soft globular uterus. Very important. Write this down. And another thing is, that's it. So UWorld में काफी सवाल है adenomyosis में and even in NBA में. So you should be thorough with this. Asherman syndrome, additions of fibrosis of endometrium, presence with decrease in fertility, recurrent pregnancy loss, and another point is often associated with dilation and keratas of intrauterine pregnancy. Now, if in the question, they will give you the dilation and keratas was done or some surgery was done before. Okay, then think about Asherman syndrome, presence of adhesions, adhesions and fibrosis. जो sutures and scars that are present in the body, that is what adhesions mean. Coming to endometrial hyperplasia, abnormal endometrial gland proliferation stimulated by excess estrogen, very very important. Increased risk for endometrial carcinoma, presence as a postmenopausal vaginal bleeding, increased risk with anovulatory cycles, hormone replacement therapy, PCOS. So all those things that are causing increase in estrogen, they will cause endometrial hyperplasia, and endometrial hyperplasia is in turn going to cause uh, endometrial carcinoma. Okay, so everything is related over here. So estrogen treatment जब भी दे रहे हो ज्यादा एक्सेस में नहीं देना रहता. Okay, coming to endometriosis, endometrium like glands trauma outside endometrial cavity, most commonly in the ovary, bilateral, pelvis peritoneum में yellow brown powder burn lesion, and in ovary appears as an endometrioma, blood filled chocolate cyst. Chocolate cyst most commonly are. Okay, and another thing that you need to remember here is presence with pelvic pain, dysmenorrhea, dyspareunia, all those stuff you need to do. And treatment is NSAID. Okay, so if they are giving you the endometrium का जो gland है, if it is seen outside endometrium, okay. Second thing, chocolate cyst. Third, they will give you things like dyspareunia, dyschezia. So dyschezia means pain with defecation. Dyspareunia means pain while having sexual intercourse, and dysmenorrhea means no menstrual cycle. Okay, so this should be present. Okay, this वाला syndrome होना चाहिए. Pain while urination, everything. Okay, so if this is there, endometriosis. Endometritis, inflammation of endometrium associated with retained products of conception following delivery. So there will be, bacterial infection most commonly. Okay, in just for bacteria, chronic endometritis shows plasma cells on histology, treatment, antibiotic. ओके, तो सिंपल है, सब में एक एक केस याद रखना है. एडिनोमायोसिस में यू हैव टू रिमेंबर एंडोमेट्रियम इनटू मायोमेट्रियम, बिग यूटेरस. एचएमएन में सम सर्जरी विल बी देयर आर स्कार्स एंड एडिशन. एंडोमेट्रियल हाइपरप्लेसिया में एक्सेस एस्ट्रोजन. एंडोमेट्रियोसिस में देयर विल बी चॉकलेट सिस्ट. ओके, एंडोमेट्राइटिस में देयर विल बी बैक्टीरियल इन्फेक्शन ऑफ एंडोमेट्रियम. ओके, कमिंग नेक्स्ट वी हैव यूट्राइन नियोप्लाज्म. एंडोमेट्रियल कार्सिनोमा देख लेते क्या है. मोस्ट कॉमन गायनेकोलॉजिक मैलिग्नेंसी प्रेजेंट विद इरेगुलर वजाइनल ब्लीडिंग. टू टाइप, endometrioid and serous. Endometrioid, most common causes of unexposed estrogen exposure that we discussed earlier, and histology shows abnormally arranged endometrial gland. Pathogenic events include loss of P10 and mismatch repair protein. All these points are important. Serous may associated with endometrial atrophy in postmenopausal females, aggressive, Samoma body is seen on histology characterized by formation of papillae and tuft. So endometrium में क्या हो रहा है? Increase in exposure, whereas serous वाले में atrophy of endometrium. Atrophy of endometrium is very high yield. You will be easily able to diagnose. Okay. Coming to leiomyoma, that is fibroid. Most common tumor in females, often associated with multiple distinct tumors. ये देखो fibroid. Okay. Incidence in black patients, and what all is important over here is estrogen sensitive. Tumor size increases with pregnancy and decreases with menopause. This line very important. Based on this, you will be able to diagnose. Okay. And 20 to 40 years में हो रहा है. This is also important. Abnormal bleeding, severe bleeding may lead to IDA. Now this is important. Walled pattern of smooth muscle bundles with this. This is what walled pattern is. So this is, you have to remember histology, pathology, and the lines that I am telling you. Okay. Leiomyosarcoma, malignant proliferation of smooth muscle arising from myometrium, arises de novo. Now, one important point: this does not arise from leiomyoma. Okay, leiomyosarcoma does not arise from leiomyoma. Keep this in mind. Usually in postmenopausal, shows single lesion with areas of necrosis. Now, this is important. How you will distinguish leiomyosarcoma from leiomyoma? सबसे पहले, they both are not related. Second, leiomyoma is seen in young patients, leiomyosarcoma old patient. Leiomyoma mein there are so many fibroids, but in leiomyosarcoma there will be area of necrosis. Single lesion will be there. Okay, and the tumor size increase with pregnancy and decrease with menopause, but in leiomyosarcoma it is occurring after menopause. All right. So these are the differences that you need to pick out, and uterine conditions are also very high. So many questions have been asked. All right. So with this, we finish our gynecology. Now focusing on the breast. So focusing on the breast, first of all, remember this image because they will ask you, they will give you this diagram and they will give you at this location which cancer will be occurring, which tumor will be occurring. Okay. So duct may remember this and lobular terminal may remember this. Now see, breast individual is not high yield, but in UL 4 to 5 questions or entire breast topic is there. And in NBME, I don't think so many questions have been asked. Okay, so let's just do it. फटाफट कर लेते हैं. Fibrocystic changes most common in premenopausal females. Present with premenstrual breast pain. Premenstrual breast pain. Often bilateral, multifocal, non-proliferative, simple cyst not necessary. Papillary apocrine not necessary. Risk of cancer not necessary. So let's just see sclerosing adenosis and epithelial hyperplasia. What is important here? HNI and stromal fibrosis associated with calcification. Okay. Slight increased risk of cancer. Whereas epithelial hyperplasia, cells in terminal duct or lobular epithelium. See, not necessary. Okay. High yield नहीं है. UL में एक सवाल है. Just go through. Inflammatory process, fat necrosis and lactational mastitis. Fat necrosis देख लेते. This is important. In NBME question was asked. Usually painless lump due to injury to breast tissue. Calcified oil cysts on mammogram. Necrotic fat and giant cells on biopsy. Okay. Occurs during breastfeeding. Lactational occurs during breastfeeding. Increased risk of bacterial infection through cracks in the nipple. Staph aureus is the most common. Okay. So ये दो you have to remember. Benign tumors. Fibroadenoma and intraductal papilloma and Phyllodes tumor. This is also high yield. Questions have been asked over here. So fibroadenoma is most common in female less than 35 years of age. Now, if they say most common benign tumor of breast or benign condition, sorry, not tumor, benign condition of breast. So you will remember fibroadenoma. Okay, most common. So let's just see what is given over here. Small, well-defined mobile mass, tumor composed of fibrous tissues and glands, increase in size and tenderness with increase in estrogen. Okay, coming to intraductal papilloma, small fibroepithelial tumor within lactiferous duct, typically beneath areola. Okay, most common cause of nipple discharge, serous or bloody. Serous or bloody is important. Okay, most common cause of nipple discharge is also important. Coming to Phyllodes tumor, large mass of connective tissue and cyst with leaf-like lobulation. Most common in fifth decade, some may become malignant. Okay, so these three are very important. Fibroadenoma आपको आया, most common condition in the breast with fibrous tissue and glands. There is movable mass. Mass will be mobile. Okay. Intraductal papilloma में there is discharge from the nipple. Either it can be serous or bloody. And phyllodes tumor में large mass and it gives leaf-like appearance. Okay. So इसके अलावा कुछ important points लिख दो. Periductal mastitis. Periductal mastitis में inflammation of subareolar ducts. It is seen in female smokers, most commonly in female smokers. Okay. Another one is mammary duct ectasia, green brown discharge. Okay, green brown discharge. So these 2 points you have to remember, and this is the leaf like that is seen in the phyllodes tumor. So inflammatory process and benign tumors are very important. Coming to gynecomastia. Gynecomastia, breast enlargement in males due to increase in estrogen compared with androgen activity. You know the causes. Okay, so causes याद रखना है आपको. Okay, so that's it. ये यहाँ पे benign breast disease में fibrocystic change are not important, but inflammatory and benign tumors are important. And yeah, please remember this because see, they have asked the location. Okay, they have asked the location, they have shown the image and they have given ABCD. You have to identify and say where this lesion is occurring. Alright, coming to breast cancer. Commonly postmenopausal, often presents as a palpable hard mass, most often in upper outer quadrant. This is important. And another thing is nipple retraction and skin dumpling will be there. Okay. Usually arises from terminal duct lobular unit, HR2, triple negative, that is ER negative, PR negative, and HR2 negative are aggressive. Risk factors in females, increase in age, history of atypical hyperplasia, family history of breast cancer. All these are important. BRCA1, BRCA2, increase in estrogen exposure, everything is important. Okay. So यहाँ पे बस यही याद रखना है कि BRCA1 is important in female, whereas in males BRCA2 is important. Okay. Now let's just see the type. Ductal carcinoma in situ. The ductal carcinoma in situ में fills ductal lumen. Then you have often seen early as a microcalcifications on mammography. Early malignancy without basement membrane penetration. This line is very important. This was asked in UL. Without basement membrane penetration. Usually does not produce a mass. Now, comedocarcinoma, subtype of DCIS, cells have high-grade nuclei with extensive central necrosis and dystrophic calcification. So this is very important. Notes वाला part. Okay, DCIS. Let me see if अगर कुछ और है. No, nothing. Okay, so calcification, necrosis, and without basement membrane penetration. Coming to Paget disease, extension of underlying DCIS or invasive breast cancer up to the lactiferous duct and into the contiguous skin of nipple. Okay, so eczematous patches over nipple and areola skin. This line is important. Eczematous patches over nipple and areola skin. UL में बहुत questions है. Okay, intraepithelial adenocarcinoma cells. This is important. Another one line, write it down. Nipple ulceration and erythema. Okay. Now, lobular carcinoma in situ. Decrease in E. cadherin expression, no mass or calcification, incidental biopsy finding. Decrease in E. cadherin expression, no mass or calcification, incidental biopsy finding. Okay, E. cadherin is important. That's it. Coming to invasive carcinoma, the first one is invasive ductal. Rock hard mass with sharp margins, duct-like cells in desmoplastic stroma. Most common type of invasive breast cancer. Invasive lobular, wherever you hear the term lobular, it has to be associated with E. cadherin. Okay. Orderly row of cells, single file like appearance. This is what they will ask you. Medullary, not important. Inflammatory is important. Dermal lymphatic space infection. Breast pain with warm, swollen, erythematous skin around exaggerated hair follicles. Poor prognosis. So usually lacks a palpable mass. Now, important over here is the inflammatory may is the only type of breast cancer where you will be given questions with pain. ओके पेन के साथ देंगे और erythematous skin around nipples swollen along with that they will give you कि there is no palpable mass also. Okay, so inflammatory is important, invasive lobular is important, invasive ductal is important, Paget disease is important and ductal carcinoma in situ is important. Okay, see breast से भी इतने सवाल नहीं आएंगे if they want to ask only one question in the entire exam. Okay, NBME is also not focused so much on breast, one or two questions in 2 3 NBMEs, but you will just focus a lot. So you will question अच्छे से कर लेना and you will be good to go. All right. So with this, we are done with the female reproductive system. Now, guys, I have to go out, and that was the reason I took the class in the morning. Don't worry, इसके लिए there won't be separate class. I will record it myself and I will send you the recording. Okay. So male and pharma जो बचा है, I will record it myself and I will send you the link. So that's it. I have to go out and so sorry for that. And the female we are done with the female part. If you have any doubt, Sharon, बता दो.
नहीं, that's all.
ओके तो ब्रेस्ट
Yeah.
वाला लाइन खाली रट लेना बाकी सब में आई हैव ऑलरेडी मार्क यू क्या क्या इंपॉर्टेंट है. ओके और मेल और ये जो ड्रग्स का है ना आई विल रिकॉर्ड इट माई सेल्फ एंड सेंड यू यू डोंट नीड टू अटेंड द क्लास. अगर आपको अटेंड करना है तो मैं आपको 1 घंटे पहले बता दूंगा. इफ यू आर फ्री यू कैन ज्वाइन. ओके
Okay, sure.
ओके दैट्स इट. इफ यू हैव डाउट यू कैन से और क्लास इज ओवर.
Yeah, no doubts. Thank
ऑल
you.
राइट ऑल राइट.